Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome to another episode of the American Academy of Orthopedic Manual Physical Therapists podcast. I'm Kevin MacPherson, and today we will be continuing our series of interviews from presenters at the 2018 AAOMPT Conference in Reno, Nevada. Specifically, today we will be interviewing Dr. Evan Petersen regarding clinical reasoning and his presentation at the conference. Now, before we get into that, here's a little bit of background on Evan. He is a hybrid practitioner in that prior to becoming a physical therapist, he became an athletic trainer and received his degree through Brigham Young University. After that, he moved into physical therapy and received his master's degree through Baylor University, and he has seemed to have a pretty strong tie to that university because he eventually got his fellowship through there, as well as his doctorate of science through Baylor. And across the end of his military career, he was in charge of their doctorate program. Since that time, he has become a faculty member at the University of the Incarnate Word, where he continues to really strive to improve clinical reasoning across the students that roll through his program. So without further ado, Evan, how are you doing today?
Excellent. Thank you, Kevin. Appreciate the opportunity to do this podcast.
Yeah, and we appreciate you being able to come on to the podcast to really elaborate on your talk, because I was able to sit in this talk and I found it two things. One, very necessary, because we all know that clinical reasoning is a very difficult skill to get students to evolve. And then two, it was validating because I tend to do a lot of the stuff that you're doing, but maybe not in as organized a process. So just to begin with, let's give the listener a little bit of background on your talk. And for those listening, the title of the talk was Putting Your Clinical Reasoning in Order, Effective Teaching and Learning Strategies for Physical Therapy Students and Educators. So, Evan, tell us about it a little bit.
Absolutely. Well, this, clinical reasoning is a very a topic that we're very passionate about. I've done this at the fellowship level training and also now at the entry level now for several years. And it just seems to be one of those things that is such an essential skill for our students and clinicians to master. And it probably is one of the more difficult ones because it's not as tangible a skill as something like a manual muscle test or doing a certain intervention. And so I've been really intrigued over the last, really decade of understanding clinical reasoning and applying it to different situations. The way this talk came about, we actually started one in 2017 with Gail Jensen and Dr. Matthew Walk, which I presented with at this AAOMPT conference, about why wait for fellowship training to learn how to reason. This was at CSM in 2017. And that was the kind of the springboard as we continued to study this and put some of these principles into practice, which resulted in this one that we just did at AAOMPT in November. It really came out from our observation of our students really having struggles with the clinical reasoning process, like you mentioned earlier. It just seems to be a little bit more sporadic for the novice learner, not as fluid, difficult to put things into practice, difficulty to take pieces of information that they have and put them in a way that they can then process that and then make sound clinical decisions. So that was one of the purposes of the title of our presentation, Putting Your Clinical Reasoning in Order. We really stress in our program a more systematic approach to clinical reasoning. And again, we've developed this tool called the CRAFT tool that has facilitated their students' reasoning. And more than that, given the educators the opportunity to see that reasoning on paper and be able to identify where some of the gaps of their clinical reasoning are happening.
Fantastic. Now, when we look at the talk you gave, you listed out 5 specific errors in clinical reasoning. And I'll just list those off from the slides you have. First is ineffective gathering and verification of pertinent information to guide that reasoning. 2 was the failure to filter and group an array of signs and symptoms into meaningful, manageable chunks of information. 3 was knowledge deficit. 4 was letting personal and professional biases cloud our reasoning processes. And then the final one was an over-reliance on heuristics, or those cognitive strategies and mental shortcuts. So do you mind giving us a little bit of a run through on how this form, the craft form, helps out with these different reasoning errors?
Absolutely. And thanks for mentioning those. That was a key piece of our presentation, which came from pretty extensive look at the literature, and not only in our profession in physical therapy, but also across the healthcare professions, and where we're making these errors. And they're again they're not just within physical therapy, but in a lot of other healthcare professions. And so as we looked at these errors, we were trying to come up with strategies to basically overcome them. So if this is an error of ineffective gathering and verification of that information, how do we teach our students how to gather that information effectively, and how do they verify that? So one of the ways we do this in our curriculum is really that this systematic approach, the way we teach them how to take the information in a specific order, that doesn't, yes, it's a little bit scripted in that regard, but the patient's still in charge. It's just being guided by the physical therapist in a more appropriate way. As they do this, the information that they get, they can actually verify. We teach them strategies like proper open-ended questions, following up with more closed questions or closed and biased questions, which might help them verify the information that they need. But more appropriately, when we do this in order, what we see our students doing is being able to process this information, and then it actually leads to the second error. Even though you can gather it effectively, if you can't process that, and in the literature it's called chunking, you're putting pieces of information into pertinent, manageable chunks of information that you can do something with. And so the way we teach this, it helps the student actually do this process as they're taking the interview. Once they do that, so that's some of the strategies that we talked about in our presentation, that really is related to the craft form, but not exactly that piece of it. We also talk about effective strategies like a body chart, and the importance of a symptom map in really understanding the patient's pain, where it is and where it's not. And then being able to take the rest of that information, the A's and E's is the past, present history, 24-hour behavior, and then we teach the students really how to do an effective medical screening to make sure that they fully understand the patient by the end of the subjective interview. So those are strategies that we taught in the AAOMPT conference presentation that really kind of attack those two first errors. The third error is about knowledge deficits. Now, this we related to, this is one of the reasons why we go to school, right? If you don't know about certain diagnoses, if you've never heard about certain interventions, the likelihood you're going to employ those is very low. And so we just made a plug for education, not only entry level, but then being that lifelong learner, continuing in and going to residency and fellowship training, because this is where we continue to gather more and more information that will hone our skills as a physical therapist. The fourth error, the letting the professional or personal biases cloud our reasoning. This is something that I think all of us just need to realize, that we all have biases. And as we first admit that to ourselves, we can then take that into process and say, even though I might love manual physical therapy, this patient that's sitting right in front of me may not really need it, or it might not be effective for him or her. And so if I've already biased myself by overthinking everybody needs manual physical therapy and exercise, then I might miss an opportunity to evaluate or treat a patient in a way that they really need it. So it's just a constant check for us. And then the last thing is the over-reliance on the heuristics, which you mentioned very well, is a cognitive strategy. It's a shortcut that we make. A simple example is some of the things that we hear routinely in physical therapy. For example, if a patient plants the leg and turns the knee, and all of a sudden hears the pop, the first thing that usually comes into our mind as physical therapists is probably sustained some sort of ligament injury, possibly ACL. And although that's not wrong, that if we don't ask the further question of where did you feel the pop, or what did you experience after it? Were you able to bear weight on it? Some of those additional follow-on questions, you can make the clinical reasoning error of just assuming that it is a ligament injury when you haven't really explored that. Well, what if that pop happened at the hip or the ankle? Then how does your reasoning change with that? So that's just a simple example of one heuristic. Again, there's many others in our profession. Transitioning then to the craft tool, what that really does is take that information that we've gained from the subjective examination and basically puts it onto paper so that the student can really see their reasoning process. And so the script or the craft tool is taken into different parts where they actually start with part of the body chart and develop some of their hypotheses based on where the pain is and where the pain is not. This helps them then develop some of the initial hypotheses, and we have them actually rank their most likely, less likely, and more remote hypotheses, considering not only orthopedic, but also non-musculoskeletal pathologies as well. Another tool that we utilize along with the craft is what's called the SINS approach, and that's been talked about and discussed quite extensively. The challenge is there's not a lot of literature published about it, but we really feel this is an area of research we're going into. The SINS tool, which stands for severity, irritability, nature, stage, and stability. The craft form actually incorporates that process of thinking and reasoning so that the therapist can really understand the patient, and then can tailor the physical exam and the intervention process to the patient's SINS. So anyway, that's a little bit of a snapshot about that. And then the rest of the craft form basically takes through different parts or different types of reasoning that the student goes through. And again, at the end of the process, this gives not only the student the opportunity to see their own reasoning, but then again, as a clinician or as an educator, we get to see what the student is thinking and why.
So there's a lot to really unpack with everything that you just said. If we start off a little bit further back into your reasoning errors, one thing that I've seen in the research was really a lot of the efforts to point out bias to students or to predominantly medical practitioners, since there's a fair amount of this research more in that realm than ours specifically. They found that teaching somebody about bias and the different types of bias, such as availability, such as anchor, these don't really impact that person when they're in clinical practice. They can help them identify after the fact, but it wasn't so much in. Now, what I've seen is that what comes to bear is exposure, experience to whatever that diagnosis is or whatever that specific presentation is. And I'm curious as to a little bit more depth, or if we could get a little bit more depth on how you help your students cross that knowledge deficit bridge. And it doesn't need to be elaborate. You can just give me kind of a 30,000 foot view.
Sure. No, that's an excellent question. You're absolutely right. And that's one of the things I think the power of this tool does is you can actually see the student's reasoning on paper. They may be able to tell you this, and in a conversation that might come up, but if they don't actually reflect on it, that metacognition skill of reflecting on how you thought, what you thought, and then putting your thinking on paper, sometimes it just doesn't become really visible and tangible for the student, and then for the clinician or the CI, the educator, it gives them an opportunity to actually evaluate that thinking a little bit more in a structured way, and then have a meeting with the student to say, wow, here's where I think you may have made this error, or here's where I think some of your biases may come out. And let me give you an example. Like the first two parts of the craft, the first part's about really identifying potential structures of sources of pain, etc. And then that takes on to that initial hypotheses. What we see very commonly in our students is just a very myopic or narrow-sighted view of where the symptoms could be coming from. Right under the symptoms, they might give you diagnoses that are very, very related to each other, but they can't take that next step out. Well, besides that, what else could this be? And many students struggle with that process. Well, the craft form actually helps the student see this and say, wow, all the maybe 6 hypotheses that I came up with were all pretty much focused on just, maybe, for example, if it's a patient with lumbar spine pain, everything is just localized in the lumbar spine. So although that's not wrong, you've really failed to understand that other things could be happening that could cause that pain in the lumbar spine. Have you considered how the thoracic spine may be contributing to this? Have you considered that this pain is coming from the hip and it's referring to the area, or the SI joint, or something like that, to help the student really expand their vision, expand their reasoning, and how they're going to systematically rule in or rule out competing hypotheses.
So to kind of ask a little bit more clarification about that response, I'm curious to how much you ask the students to ante up for their hypotheses. Are they trying to list their hypotheses in order of probability as well as just putting them on the form? How are you using the 1, 2, 3 for your most likely, least likely, and very remote hypotheses?
That's an excellent question. And there's actually 2 sections on the craft that actually does this for the student. They make an initial hypothesis after the body chart, which is that first thing after you've gotten to know the patient, to establish the patient profile. We teach them how to take an effective symptom map. And then really right after that, they're encouraged to, okay, so what is your initial hypotheses right after that body chart? What are you thinking right now? And then as they progress through the exam, they have the opportunity at the end of the subjective exam to then refine that hypothesis to say, well, I thought it was this, but in doing the medical screening, in taking the AGS and EAS factors, in doing this 24-hour behavior, the additional gathering of that information, I find that this hypothesis is not well supported, whereas this other one is actually more supported. So I'm going to make a clinical decision then to treat this, or to evaluate this first, rather than this first one that I was thought. So that also helps the clinician and also the educator see that reasoning, how it changes, because most novice and beginner therapists, they the first thing that they think about, they typically just stick with, and because that's what maybe they know very well, and then they'll just go with that, and at the expense of everything else. They don't really systematically rule in and rule out competing hypotheses. And this is what the craft form actually does, is help the student realize that, oh, wow, I am thinking pretty myopically. I'm not thinking more broad, and I'm not asking questions to rule these other things out. And so I'm ended up with what I thought it was in the beginning, and now that's more like confirmation biased. And so the form does help check some of your biases as you go through the process.
Now, speaking of bias, you have mentioned 2 things that I want to clarify to the listener. One is that error in reasoning number 4, where you're looking to limit some of the personal and professional bias. But you also made mention of subjective questioning, in where you might want to use a question that is biased. Do you mind just clarifying that up for the listener?
Absolutely. So this is another strategy we really teach our students to combat some of these clinical reasoning errors. Because again, if your questioning skills are poor, you're going to receive information that's very poor. And so we have some interesting strategies that we utilize in the classroom to help our students utilize their questioning skills, of really opening up each section of the interview with more of an open-ended question, and then really forcing them to listen to the patient's response, and then asking the follow-on question, which may be an additional open-ended, or maybe more closed-ended or closed and biased question, to clarify information that the student or that the patient may have said. So basically, just verifying that information that the patient said. So what you're saying is this, or do I understand you to mean this? And that way you're building that rapport with the patient and really understanding where they're coming from. And so at the end of the subjective exam, you really truly understand, what the patient, who the patient is, what their problem is, and how to maybe effectively address it. So those questioning skills absolutely are crucial. They go right along with the tool, but and they'll see this sometimes when they take their exam and then they go put it on this clinical reasoning tool. They'll see their huge gaps because they'll realize, oh my goodness, I haven't even asked about that, or I didn't even consider competing hypotheses. So this tool will help them realize some of their gaps in the clinical reasoning process.
So towards the end of your response there, Evan, you mentioned kind of that contextual presentation that the student is trying to get from the patient in an appropriate and clear way. And that's one of the things that comes from a reference. I believe your reference was Edwards 2004, looking at clinical reasoning and physical therapy. And they talked about two different reasoning processes or things to consider for a patient. One was that empirical component of it. The other was more of a narrative aspect to it. When I look at the craft form, you're describing some of that more global, who is the person in front of me, as opposed to just what is this presentation. In the craft form, I see that tends to be pushed back a little bit into, I believe it's section 5.
That's correct.
Which is after that initial intake, after considering how much you want to push the patient during evaluation. So are we waiting to that time point, or are you having them consider those aspects a little sooner?
That's a great question. In fact, a couple of other clinicians and educators brought that to our attention during the AAOMPT conference, which I thought is great, and it's a absolute good critique of the form because it looks like, from the form standpoint, that this is really more of an afterthought. It's in the later sections of the craft, and it's really not intended to be that way, because really this is a way for the student to actually put their thinking in an organized fashion so that they can reason where they're making the errors in which part of the reasoning. And you said it well, the contextual factors is an absolute crucial part of understanding the patient. It just happens to be in a section that's a little bit further down in the tool, but that doesn't necessarily make it less important. It's just where it's located in the tool. Where the student actually learns and how to get those contextual factors is through the whole entire patient-client management process. In other words, they're already starting to understand the patient the way we teach them how to take the history. They're starting out with the patient profile. So before they even ask about where your pain is, how did you hurt yourself, etc., the student it learns how to take those contextual factors, such as who you are, what your likes and dislikes, what is your work environment like, what's your home environment. They do that patient profile section first, really, and then move into the body chart, then move into some of the Ags and Es, and then throughout that process, they end up the subjective exam with what are your goals, how do you learn best, how can what's the things that I can help you most with as a physical therapist. So that process is really fluid throughout the patient client management encounter, and then they take all of that information that they've gathered, and then they put that in sections of the craft. So again, the sections of the craft are not necessarily in order of importance. It's just more putting them in a way to chunk the information to say, okay, wow, you really didn't consider, like for example, if they did a really good job on the first 4 sections of the craft, and then you get to the 5th section and you see that they didn't consider any of the contextual factors that the patient, how this disease or how this problem might have affected them. They'll be able to see that easily because none of the boxes will be checked on, for example, societal factors or health and wellness or occupational things. It's like you didn't even consider how this problem is affecting this person's ability to live because he's lost his job. He's been out of work for 2 weeks, and you didn't even address that as the physical therapist. So even though you got the right diagnosis and you're probably right on board with that, you really haven't considered how this is affecting the person per se. So yeah, that's a valid critique of the form. It's not meant to be hierarchical. It's just more of putting it into the category so it could be easily read and interpreted.
Thank you for really clarifying the way you use this form, because I think, were I to just pull this off of a journal website or whatnot, I would have a little bit of disconnect with that. So knowing how you use that form is very beneficial to both me and I'm sure many of the listeners. Now, last kind of question, if not maybe one clarifying biased question to follow up with. So obviously the craft looks like it's an expansion of another form, that scripts form. And in your presentation, you spoke about the differences in how you use it with students, where that script form is more, you're using it with that patient right in front of you, or you've stepped out and very quickly are filling it out while that person is still available. Whereas with this form, it can be used in a different way in the curriculum. Do you mind speaking just a little bit how you use it across your curriculum?
Absolutely. Yeah, thank you. And you're absolutely right. The script tool that we published in January of 2017, that came out in the Physical Therapy Journal, was a publication that when I was in the fellowship director at the Army Baylor University Orthopedic Manual Physical Therapy Fellowship Program, some of the fellows and faculty members got this tool together that we had been using for several years and decided to publish it as this is how we use it. This is our clinical reasoning process. This is really facilitating our fellows in that process. So that's where that publication came from. SCRIPT, again, is an acronym for, the SCRIPT stands for Systematic Clinical Reasoning in Physical Therapy. So that tool really is more manual therapy focused at really the post-professional level in PT. We utilize it in the fellowship program in one-on-one mentorship sessions and in the clinical examination process. Because of that, it's really less detailed. It's only 2 pages long. It really facilitates that little bit more advanced learner because it already supposes that learner to know some of these things about contextual factors or some of these prognoses and other types of things that maybe a more experienced physical therapist who's already licensed and maybe been through a residency program may already understand, but still needs some guidance on clinical reasoning and that effectiveness process of understanding the patient. So when we, and a little bit of background about this, so after I retired from the military, again, that we had just in the process of publishing that tool, I retired from the military and was hired on here at the University of Incarnate Word. And I was hired on to teach the patient-client management thread of our program and got to meet Dr. Matt Block, who teaches the clinical reasoning thread of our program. So at the same time, Matt has a very similar background than I do. He graduated from the Kaiser Fellowship, Manual Physical Therapy Fellowship in California, and was working actually on similar types of forms. He had not seen the script before, but took some of the tools that he used in his fellowship program and was trying to adapt it to the entry-level learner. And so as we started talking, because we teach in the same year group, I'm like, "Oh, Matt, look at this product. This is what we have used in the fellowship program." And he's like, "Yes, this is very similar to what I used in the fellowship program." We both loved it because it really facilitated our learning when we were, fellows in those programs. And so that began that process of really saying, well, how can we adapt this to the more entry level? And so that was a process over about a year and a half that we worked together to modify the script to expand it. And now it's really focused on more general orthopedic reasoning at the entry level physical therapist or student level. It really is, it's not effective in utilizing the clinical setting, like in an ongoing clinical encounter, just because of the length of it. So it's really to be used more. It could be used in the classroom setting or a group tutorial setting. We actually use it not only for that purpose, but we also utilize it as an assessment in our practical examination at the end of our semesters. We call it the OSCE, or Objective Structured Clinical Exam. And so we actually use that tool to both teach and assess our students' clinical reasoning abilities. It is absolutely an extension of the script. Adaptation is probably a better word for that. It is more detailed. There's a lot more guidance in the form than the script because of we're dealing with novice learners, people who are really still trying to wrap their brains about not only physical therapy process but also the clinical reasoning in those processes.
Thank you for the clarification. I think that's, again, going to be beneficial for those individuals who are looking to use this form or that scripts form and process in their training or mentorship.
Yeah.
So having discussed a lot of that, what I'd like to get an idea of is just your future projects. What do you have going on down the pipeline, of which I think I heard earlier, at least one of those might be some research revolving around SINs?
Absolutely. Let me back up just a little bit upon that. This, even though this tool is something that we feel is effective, just using one program is each program I'm sure has their own way of doing things, and that's fine. But it's interesting. Dr. Gail Jensen and her colleagues at Creighton have really identified, done a lot of good research in clinical reasoning, and have identified that there's, even though we know a lot about clinical reasoning, there's still a lack of consistency in the PT education on really how it's defined, how it's taught, how it's assessed. And so we're looking for best practices. And again, I'm not saying that this is the end all be all yet, but we're looking for ways in which, how do I assess a patient's clinical reasoning ability? Now we have this form, we have this tool called the CRAFT, which again stands for the Clinical Reasoning Assessment for Thinking Effectively. This form really has not been, there's no reliability to it. It's not been validated. So again, to utilize it in a more global way, we would have to do those types of studies first. And so we were very pleased with some of the educators that came to us after the conference and inquired about this. Some have actually asked to utilize it in our program, in their programs, because one of the things we were worried about was, we have at UIW, University Incarnate Word, we have a problem-based learning curriculum. And so that's pretty unique in comparison to the majority of education formats that are out there. And we were concerned that maybe this is really effective for our program because of our format. We have an entire thread that's all about clinical reasoning. So we were excited to see other educators who were coming from other more traditional programs wanting to utilize this. So we have shared the tool with them, and they're in the process of using it and then giving us feedback about it. And then our next step really is to do some of these research on establishing the reliability and validity of the tool and how it's really affecting a student's ability to learn.
I got to take a second because that's a fascinating statement you just said, because when I think about kind of core issues with especially outpatient orthopedic physical therapy is just the idea of not having a true gold standard for a diagnostic label. I think it's going to lead to some very, very good discussion on usage from a diagnostic standpoint. I think it's obvious when you look at both forms, the benefits that will be received from an assessment as well as from an actual treatment prescription program. But as you're talking, I just think about just some of the difficulties, however, some of the very robust discussions that will likely come from looking at trying to enhance this process. I felt the need to really point that out and say that.
No, absolutely. I agree with you 100%, Kevin. This is an area where I think we as educators and advanced clinicians can really need to get together more often and discuss these things and see what works and see what doesn't work. I need to give some kudos to Gail Jensen and her colleagues at Creighton. They actually held a conference in I believe it was in 2017, about just a clinical reasoning conference per se that they held there at Creighton. And they brought a lot of these educators from different universities to really share their ideas, and balance, what we know versus what we don't know, what's effective versus what's not effective. And it was very enlightening to be able to have these types of conversations that you're talking about with experienced clinicians, other researchers, et cetera, to really explore this. It's a need I think we all see. The challenge is this is a skill that is not very concrete, and people might have their likes and dislikes and their way to do an evaluation and that type of thing. But in the end, I think we're all focused on getting the patient better, understanding them, and restoring them to normal mobility and strength. But that process is not always perfect. That is a challenging process because we're dealing with such a huge variety of patients and conditions. A thought as you were talking too is, I wanted to mention that another critique of the form is that it really is more orthopedic centric. It has not really been. Some of the people who came up to us afterwards and said, "Well, this is great what you're doing, but I don't see its utilization in like neurological settings or with patient pediatric or others." And we fully admit that this is much more of an orthopedic biased type of form, and is utilized in that setting. We were starting to some of those dialogues with the physical therapists who are experts in neurology and pediatrics to help us develop something that's similar in their domains, so that they can do this. We feel that the process is the same. Maybe the tool just needs to be modified somewhat to focus on theirs as well. But absolutely agree with you, Kevin, that this is an area that we need to continue to do research in, continue to explore, continue to collaborate, so that we can find those best evidence-based practices and something that we're more unified on rather than being so diverse in how we think and how we act.
Great clarifications and great expanding upon the subject matter there, Evan. So the last thing that I like to ask our interviewees is, what advice would you give to a practitioner who may be considering a fellowship?
That's a great question. But first of all, I would encourage it. I think that goes back to our, one of the clinical reasoning errors is the third one was knowledge deficits. You're going to make errors if you really have the lack of information or lack of knowledge. And so being that lifelong learner of after PT school, continuing to attend conferences like the AAOMPT conference or CSM or the next conference in physical therapy. These are things that we need to be doing as a professional, to advance our skills, to continue to keep up to date on the current knowledge. Those are wonderful as well, but sometimes in a weekend course or a week-long conference, you might get pieces and parts of information that you don't know how to employ very effectively in your clinic or in your teaching style. And so I think going to residency and fellowship level type of training is a little bit more effective in that regard. So I would highly encourage all those who are considering advanced training to pursue that. There is evidence in the literature that shows that is really beneficial, not only in how effective you are as a clinician or a practitioner, makes you more marketable, things like that. My only caveat, I think, to that is just make sure you do your research. Not all fellowships and residencies are made alike. I'm not trying to say good or bad about each of them. I'm more concerned about the actual learner, to make sure that they're doing the research on does this fit them? You need to find the one that fits your budget, find the one that fits your time constraints, your family situation, your personal situation, that type of thing. Is this the right thing for you right now? Because as an educator now for the past several years, I've seen our students pursue this, at some of them at the perfect time for them, and others maybe that it's not the right time for them, or they got into something that they really didn't research very well, didn't realize that they taught this way, or I had to travel as much or whatever. So my counsel to anyone who is seeking advanced education is just do your research, ask a lot of questions to each of them, compare and contrast, and choose the one that's really best fit for you as a learner.
That's excellent advice, Evan. And one, just to finish up this conversation, I'm sure there's going to be individuals out there who might want to ask you a few more questions. What's the best way that they might be able to reach you?
Absolutely. And they're more than welcome to be happy to answer any additional questions or follow on thing that they might have. You can reach me by email. My email address is epeterse@uiwtx.edu. That's probably the best way to get a hold of me. You're welcome to also call me on my work phone here at University Incarnate Word, and my phone number is 210-283-6916.
And to Dr. Evan Petersen, thank you so much for your time. Thank you for your efforts in our profession. And thank you for a wonderful presentation at the 2018 AAOMPT Conference. I hope you have a wonderful day.
Thank you very much, Kevin. I appreciate the opportunity.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.